Hey, welcome again to the next another exciting CME talk, which we do monthly, 2 hour CME, and this time we have got a time tested crew. There's a time tested. They have actually we have had them go through the they call it prelims. They actually had to qualify for this meeting today. The reason I'm saying this that previously all our CME speakers we go by the fact that okay they are good speakers and stuff like that, but these guys have gone through a test round and they have qualified and. Today we're going to look forward to an excellent panel of speakers. The reason I say this, guys, is because these are the people who actually presented at the CME at Patagonia. Patagonia, we had a CME cruise, and then we thought, Tarak and our chair and co-chair Tarak and Atul came up with the plan that hey, those talks were wonderful. Why don't we just select four of those talks? This is not to say that the other talks were not good. I'm just joking. This is not like a sprint. We just had these four talks would we thought would be more interesting to the general public. I mean, this is kind of I always have tried to do topics which is of interest to every specialty. So that's the reason we kind of they selected the topics. That does not undermine any of the other talks. All the talks were excellent, and there was no prizes or anything like that given for that. But these things were very interesting. And as you know, with my receding hairline, I'm looking forward to Balwant again reinforcing the hair loss story. And I'm sure many of our API members are also looking forward to what pearls he's going to give us for that. Of course, we have got the couple of three other very, very good talks. And I will not steal the thunder from Tarak and Atul for them to introduce those speakers. Again, like I said, thank you very much for attending. A couple of disclaimers for people who might leave before I get to do this at the end of the talk is that next month we will not have a CME. We will be in Global Summit in India, and we are doing a great global summit there with a and it's very easy. You can go to summit.aapiusa.org and see the program and stuff like that. It's a very packed, beautiful set program. Please go and at least look at the program on the Summit website. We have a separate website for that. Having said that, we will have the CME resume on the third Sunday of February. So that's all. Over to you guys.
Okay, thank you, Amit. And I'm going to give it to Atul quickly. This is 2 hour CME. You have to register, and then after 2 week, like 5 days, by Thursday or Friday, you'll get an email from eMed Events, not from API, but eMed Events. That's the CME company. And once you get that email, you fill it out, the evaluation, and you get the CME right away in your mailbox. So please do that. This is a 2 hours with three speakers. So let's go. Atul, over to you.
Thank you, Tarak. And in case the audience is wondering why the choice of the topics, apart from the excellent speaking ability of the speakers, I mean, think about it. You first need hair to get anywhere. Sorry, so not to everyone, but you first need hair. Then you need to survive the COVID. And my God, if you do survive COVID, then you need to survive sudden death and coronary artery disease, which is highly prevalent in us. And the second point, which before I introduce the first speaker, and you look at all four or five of us, you look at Amit, and you look at Tarant, and you look at me, and you look at Praful, and of course, Balwant, and you'll understand why it is Balwant speaking on hair, and I'm the one who suggested it. So you can understand the choice of speakers here, but without much ado, Balwant Arora is something. I mean, his academic sort of credentials are amazing. He's done so much work out of Colombia. I really got to know him in Patagonia. Apart from all the work he's done, what impressed me was the selfless work he does there in sort of charity clinics and what have you in his neck of the woods. So I think in medicine, apart from the accolades he has, that is incredible. I will just pass the mic to Balwant and to start his talk without wasting too much time. But needless to say, he's very accomplished and selfless. Over to you, Balwant. Balwant is still mute, actually. We have to unmute.
I got it. Okay. Thank you, Dr. Atul Bhai, for the kind words. Thank you, Amit ji. Thank you, Dr. Vasavada. Thank you, Praful Bhai, and thank you, fellow physicians. Let me start sharing the presentation. Okay. So, I'm a board certified plastic reconstructive cosmetic surgeon. I'm also a hair restoration physician, hair transplant surgeon. And I'm glad that I passed the pre-qualifying rounds at Patagonia, which was a wonderful trip, creating memories with so many of you, and looking forward to more trips in time to come with API members. I have no conflict of interest. So, luscious hair is considered a hallmark of facial attractiveness with a natural hairline framing the face and symbolizing youthfulness. Androgenetic alopecia, which is the most common type of hair loss,
Balwant, is your slide shared?
Yes.
Is it shared? Atul, can you see his slides?
No, I can't. I thought you were giving an
please share it
introduction.
because I still have option to share. So
1 minute.
just a minute. Sorry.
Yeah. No. I'm glad that you mentioned it. I'm not sure why that happened.
Yeah, I think Atul, we gave it to Atul. Remember for a while?
Yeah.
Yeah, but I exited the slides.
No, you did. But then Balwant may not have gone back to share his thing.
Okay. Now one can see.
It's coming in a second.
Okay.
Yep.
See?
Start from the first one. Yes.
Yeah. So, luscious hair is considered a hallmark of facial attractiveness with a natural hairline framing the face and symbolizing youthfulness. Androgenetic alopecia, which is the most common type of hair loss, has a lifetime prevalence of up to 80% in men and 50% in women, respectively. And according to psychological findings, healthy and strong hair signals overall good physical health, stamina, and reproductive potential. In this day of social media, your hair is 90% of your selfie. So hair is one of the fastest growing tissues in the human body, along the lines of bone marrow and the lining of the GI tract. The hair follicle, which is a unique characteristics of animal, represent a stem cell rich prototypic neuroectodermal mesodermal interaction systems. The hair follicles, they undergo repetitive regenerative cycles: anagen, growth phase lasting 3 to 6 years, catagen 1 to 2 weeks, and telogen 10 to 12 weeks. 85% of the hair is in growing phase and 10 to 15% of hair is in telogen phase. Their function is friction buffer, beauty, protection, and insulation. Now, hair integrity is determined by the intricate building blocks of many layers of hair follicle, but it relies on proper nutrition. Now, weak hair can result from internal factors such as inadequate nutrition and external factors such as physical trauma, heat manipulation, as well as chemicals. In a nutshell, healthy hair reflects a healthy body. So, hair growth is a continuous cycle from anagen to telogen, and then hair come back to anagen. So, as I said earlier, the anagen phase can last 3 to 6 years. Let's assume that it is lasting 6 years. An individual who is going to live 100 years, that hair follicle is going to recycle for 16 plus cycles in the lifetime. Now, balding is not because the hair is falling. Balding is because the fallen hair is not replaced with a new hair. There is a new phase, what is known as kenogen phase. It is an empty follicle phase. The density of the hair in blonde is 140,000, brown 110,000, black 108,000, red 80,000, and in Indian population the average is 80 to 120,000. The prevalence of hair loss in males and females is in various studies is shown in this slide, but by and large we can safely say that it is 30% by the age of 30, 50% by the age of 50, and 80% by the age of 70 in males, while 75% of the premenopausal women, they require hair loss treatment. Now, in Indian demographics, 50% of population below 25 years of age, 65% of the population before 35 years of age with disposable income, and for the need to look good, 50% of these are looking for the hair loss remedies. The global hair restoration market was estimated at 6.46 billion in 2023, and it is expected to expand at a compounded annual growth rate of 16.6% from 2024 onward to 2030. The growth is primarily attributed to the increasing prevalence of androgenetic alopecia, which is a key driver in the hair transplant system market. Lifestyle factors such as excessive tobacco, alcohol consumption, along with rising stress levels are considered significant triggers for this condition. Additionally, factors such as rising disposable incomes and a growing emphasis on aesthetics are expected to further drive the market growth. The classification of hair loss is broadly categorized into three groups: scarring alopecia, non-scarring alopecia, and mixed alopecia, where there is a component of scarring as well as non-scarring. And some of the causes are mentioned over here, including lichen planopilaris, CCCA, folliculitis decalvans, pseudopelade of Brock, frontal fibrosing alopecia, tinea capitis, dissecting cellulitis of the scalp. In the non-scarring ones are androgenetic alopecia, which is also known as male pattern hair loss, then female pattern hair loss, telogen effluvium, diffuse unpatterned alopecia, trichotillomania or hair pulling, and alopecia areata, which is an immunological condition, autoimmune. While the mixed one has cicatricial pattern hair loss, fibrosing alopecia in pattern distribution mimicking as androgenetic alopecia, lichen planopilaris mimicking as androgenetic alopecia, and also overlapping clinical presentation. Now, study of Indian genetic traits. It is very important to remember that this have covered 2.6 crore undocumented genetic variant, adding over 1.6 crore of protein altering genes to a global database, which include Indian genetic traits connected to metabolic disorders, which is very important here. Then the team studying the links between the protein metabolism and the origin of disease, which appears to be a common trait appearing in the Indian gene mapping. The tradition of marriages within the Indian community has preserved and amplified the ancestral gene pool over generations. And Indians have 2 to 9 times homozygosity, making it more likely to inherit same gene from both the parents, making even a recessive disorder to easily manifest. The data indicates that Indians are more prone to metabolic disorders, again emphasizing metabolic disorder, and should add preventive measures at a younger age. So, common clinical presentation of the hair loss along the spectrum from LPP to telogen effluvium, if you look at it, genetic is androgenetic, hormonal, inflammatory, autoimmune, and scarring as well as non-scarring. So, looking for a solution for these conditions is interpreted as causes. These are the effects and not the causes, because hair loss is multifactorial. It is very difficult to pinpoint just one factor contributing by and large in majority of the individuals in this day and age, and especially more and more so in the younger group. What happens is that various causes make the follicle weak, vulnerable, sensitive to inflammation, immunity, and action of DHT, creating loss at cellular function, poor growth, and miniaturization. Modern research shows that causes and pathways are acting together simultaneously all over the scalp, but only weak, vulnerable follicles, they succumb, while stronger follicles can resist and recover. And this is where the whole emphasis of medical management comes from the nutrition point of view to make the hair follicle stronger. So DHT is not the only factor. There are evidence on the role of non-androgenetic factors in AGA, and there are 25 such studies which are broadly categorized into 4 different groups: metabolic, environmental, lifestyle, and nutritional. Essentially, polygenetic inheritance encourages different phenotypes. So androgenetic alopecia does not have a single gene Mendelian inheritance, but a polygenetic inheritance. These polygenes, they interact with each other and also with other alleles. Polygenes are vulnerable to the influence of multiple environmental, lifestyle, nutritional, sleep, and stress factors, creating different traits and phenotypes. Identical twins do not evolve the same way. That means genetic predisposition does not work alone. there are multiple other epigenetic factors which change the expression of genetic factors. Polygenes, they react with other genes and with alleles on the genes, exposing themselves to the influence from multiple factors. Hair loss genes are associated with other genes responsible for the impaired metabolism of arginine, glutamine, methionine, homocysteine, lactic dehydrogenase, lipids, and insulin resistance. Raised VLDL is now regarded as a biomarker of AGA. ROS, they upregulate the androgen expression and activate androgen pathways. So ROS, they lower the threshold of androgen receptor, leading to acquired androgen sensitivity. And this androgen receptors has been identified to be a phosphoprotein in nature, and hence it is influenced by inflammation, protein synthesis, energy metabolism, cell proliferation, and homeostasis through accumulation of ROS. They also cause the upregulation of androgen expression and activation of androgenetic pathways. And this involves the evidence of micrometabolic dysfunction, which is mediated by ROS, leading to anagen arrest or telogen extension by interruption of the hair fall, resulting into inability of the hair that is lost to be replaced. So multiple factors are there which can be broadly categorized as oxidative stress, inflammation, immunity and autoimmunity, metabolic, senescence, smoking alcohol, stress, pollution, electromagnetic radiation, seasonal changes, gut dysbiosis, as well as epigenetics. So DHT has no direct role in any of these mechanisms. Now there are 6 different phenotypes which are mediated by ROS causing metabolic dysfunctions, and these 6 different phenotypes are oxidative stress phenotype, epigenetic phenotype, inflamed aging phenotype, senescence phenotype, immune senescence phenotype, and metabolic quiescence phenotype. So ROS, they mediate multifactorial hair loss and sensitize, as shown in this diagram, altered immunity, autoimmune reaction, metabolic impacting the metabolic regulation, aging, DNA damage, release of cytokines, interleukin, activation and upregulation of TGF factor beta, sensitization of androgen receptors, and activation of the androgen pathways, promoting the inflammation again. So the presentation has changed and it is not hormonal anymore. All these factors, they impact, and essentially non-hormonal factors are rising exponentially, and hence we are seeing hair loss more and more in the younger age group. These factors, they weaken follicles, imbalance, cause dysregulation, impact genetic expression, and hair follicles susceptible to normal DHT. Again, active metabolism maintains the hair cycle. Interruption of cellular function lead to newly defined empty follicle phase, what is known as kinogen. And AGA is identified by anagen arrest or telogen extension, which is caused by multiple factors. So coming to the management, it is broadly categorized into medical management and surgical management. And the medical management has medications which are finasteride and minoxidil. These are the main ones, but there are others also like dutasteride. Then there is nutritional supplement, and then there is low level laser or light therapy on the medical side. And I'll also come to the procedural management little later. So what is finasteride? It is a competitive inhibitor of type 2 5 alpha reductase, the isotype most common in hair follicle. It is administered orally at a dose of 1 milligram per day. Side effects include loss of libido or erectile dysfunction. The incidence is 0.3%. In the older age group from 41 onward, the overall incidence of side effects is 8.7%. Now, finasteride is also known to reduce serum prostate specific antigen PSA levels by 30 to 50%. So, men over the age of 40 who are advised to have finasteride should have their PSA levels doubled for interpretation for evaluation of the prostate. Finasteride has limited efficacy because the study that was done was for 1 year, which reported overall benefit in 48 to 52% users, and 17% of the users had in fact deteriorated. Remember, hair loss is not a sickness or a disease to be cured by a drug treatment. There is also an entity which is a recognized health disorder known as post-finasteride syndrome, characterized by anxiety, depression, suicide, sexual dysfunction, and has such psychic effect. And there is an FDA warning for the permanent side effects. Also, these studies submitted were not double blind, and they were short term, and there was the design was inadequate. In fact, the 4 years ago, the citizens, the Post Finasteride Syndrome Foundation filed a citizen petition requesting that FDA withdraw its approval for Propecia, which is the brand name of finasteride by Merck, for the treatment of male pattern hair loss due to significant risk that drug poses to the patients. Alternatively, PFSF also requested that FDA require drug manufacturers to revise the safety information on the labeling and add boxed warning to disclose the risky potential side effects. Coming to procedural management, this includes platelet-rich plasma, Caralase, exosome therapy, and scalp micropigmentation. As we know, platelet-rich plasma has emerged as a treatment modality in regenerative plastic surgery and also in other fields, and the preliminary evidence suggests that it has beneficial role in hair regrowth. It effectively stimulates follicular and perifollicular angiogenesis, which is suggested to be one of the major factors in active growth. It is performed every 4 weeks for 3 times. If the individual responds, then more can be done, but otherwise, if there is, the 3 are enough for the individuals to get the response. Coming to Caralase. So Caralase is a laser application as well as Carafactor application. So a laser, which is a thulium laser, which has 1960 nanometer wavelength, this laser creates tiny microchannels in the scalp, which helps to increase the absorption of Carafactor. So this Carafactor serum is then applied and massaged onto the scalp. And this Carafactor serum has highly concentrated level of growth factors and proteins. These are bioactive growth, bioidentical growth factors, and these are 5 of the most important growth factors, proteins that specifically boost hair growth and affects all the 4 stages of the hair life cycle. And usually 6 such sessions are recommended, one at the interval of every 2 to 4 weeks. Coming to exosome therapy, exosomes, as we all know, are tiny communication vesicles within the cells that give them their incredible power to regenerate new tissues, including hair. Exosomes carry active RNA codes in encapsulated vesicles. Now, these tiny vesicles are only 1,000th the size of a stem cell, contain over 1,000 protein growth factors. Proteins delivered in exosomes, they provide cellular communications that signal healing, anti-inflammatory responses, and cellular growth. In nutshell, exosomes deliver wake-up signals to dormant follicles and stimulate the production of new hair cells. Now, we have to keep this in mind that all this therapy works on the foundation of the nutrition, which is the basic to which I am going to come in a short while. Coming to scalp micropigmentation. These treatments are a camouflage hair loss solutions for men and women. SMP involves replicating the appearance of a shaven hair by introducing thousands of tiny pigment deposits into the dermis of the scalp. When placed by a skilled technician, the recipient appears as if they have a full head of hair shaved to a very, very short length, hiding the appearance of pattern baldness or even complete baldness. Coming to hair cloning and stem cells, there is a lot of buzz about hair cloning and stem cells nowadays, and there is also a hair bank. So growth factors, they are extracted from the cultured cells, are offered as stem cell treatments and exosomes. Regenera offers lysed cell extract from the donor follicles to be injected as growth factor concentration and stem cell therapy. Now, human follicles has dual embryonic origin from ectoderm and mesoderm. So it is very difficult to culture or clone this because the media that is required for culturing the tissues coming from the ectoderm and mesoderm is very different. These are only for laboratory purposes. There is no FDA approval. There is no clinical success so far. Please remember, there is no lack of stem cells in a balding scalp. What is missing is the mechanism of growth, and which can help achieve medical multiplication and medical cloning with better understanding. So this comes to the most important aspect, which is intermittent cyclical vitamin therapy, where synergism lowers the dosage and improves efficiency. Remember, majority of us are taking multivitamin a day. But there is a smarter way to take supplements. See, as there is drug to drug interaction, there is food to food interaction, so is nutrient to nutrient interaction. See, multiple nutrients together interfere with the absorption and efficiency. So what you need to do is you need to take different supplements as shown here. On Monday and Thursday, you take antioxidants, calcium and omega 3. On Tuesday and Friday, you take iron, folic acid and vitamin C. On Wednesday and Saturday, you take amino acids, B complex and biotin. So basically, you are taking complementary supplements on a different days in a cyclical manner. Thus, you are lowering the dosage, but at the same time, you are improving the efficiency and the absorption. So there is optimization of synergistic nutrients in a biological proportion. It avoids nutrient antagonism. It prevents hypervitaminosis. It includes a comprehensive wide range of nutrients. It addresses the covert and undetected subclinical deficiencies. It provides long-term safety without any fear of side effects, and it is cost effective and it is efficient. So in a controlled clinical trial of 100 men with 2% minoxidil plus 1 milligram finasteride, 100 women only 2% minoxidil 1 year follow-up, they were compared with individuals taking cyclical nutrition therapy plus using 2% minoxidil in female and male. The findings were hair loss was controlled within 4 to 6 weeks. Average improvement in the density was 18% at 2 months and 30% at 4 months, while in the control groups results were only seen after 6 to 9 months. Average improvement in the hair caliber was 9% at 2 months and 21% at 4 months. There were no non-responders. It also benefits in hair loss due to stress, pollution, smoking, cell phone radiation, other hair shaft disorders also. Now, we get the food from the soil, and why it is very important to know this. The trace soil minerals are a critical component of both crop productivity and mineral concentration of crops, therefore potentially impacting the nutritional status of the human population relying on these crops. Now, the study utilized the data of 27 million soil samples in India, and surveyed over 1 million individuals in India to assess the importance of soil zinc and iron availability and compare it with the measures of physical growth and hemoglobin levels, and this was directly proportional. Where there was deficiency, there was presence of these factors. These are some of the, and hence taking the nutritional supplements has become very important in nowadays. These are the results before and after with the 4 months of cyclical nutrition without the use of finasteride. These are trichoscopic findings. This is before and after 4 months. Only supplements and minoxidil, no finasteride, no other intervention. Coming to surgical, there are broadly 2 categories: follicular unit transplantation, which is known as FUT or strip procedure, and follicular unit excision or punch procedure. So in a strip procedure, we basically take a strip, then we sliver it, then we dissect the graft, and then we implant it. In the FUE technique, we take every hair with a punch one by one, and then we go ahead and implant it. There are also new drugs under development. Clascoterone is a topical medication primarily used to treat acne. However, it is also being studied in a higher concentration for its potential to treat androgenetic alopecia. It works by inhibiting the effects of DHT directly at the scalp, according to the pharmaceutical that is doing the study. It works locally without affecting the hormones throughout the body. One can think of it as a non-hormonal topical DHT blocker designed to slow hair loss and potentially regrow hair, especially useful for people who are sensitive to pills or worried about the systemic side effects. PP405. It is a promising compound that may help in hair regrowth by reawakening dormant hair follicles. It works by inhibiting a protein in follicle stem cells which keeps these cells dormant, thus potentially allowing for natural hair regrowth without surgery. Early trials show that 31% of the participants in phase 2A trial experienced over 20% increase in hair density, with further studies planned for 2026. The researchers dubbed the transporting molecules as PP405 as a tribute to the headache the LA residents have to deal with the 405 freeway over there. So, in a nutshell, health of an individual's reflection is hair. See, remember, hair is optional for us. Our body is designed in such a way that whenever there is disease, whenever there is stress, the body selectively takes away nutrients from the hair follicles and utilizes this to create the antibodies to fight the disease process. We know that following COVID, hair loss is now an entity established 4 to 6 weeks down the road or little later, because to fight the COVID, the body selectively takes away nutrients from the hair follicles, makes it weak, and utilizes that to create the antibodies to fight. So when we start these treatments, it basically resets all the cells first before it reaches the hair. So this treatment not only helps the hair, but it actually helps the whole body. And remember, invest in your hair, as it is the only crown you never take off. Thank you.
Very nice, Balwant. Can you hear me? As always,
Yes.
very educational. Um, I will. I was thinking initially we'll have all questions later, but maybe we can address a couple of questions as they are very sort of fresh in our minds. One is someone asked, yes, you can have a copy of the slides if it's okay with the speakers. I'm sure it's okay
Yeah.
at the end of the presentation. There was a question on one. I'll just put both the questions which just passed me. One was the mechanism of minoxidil.
Yeah.
I mean, one thinks of it as a supplement, as an antihypertensive. So one is mechanism of minoxidil.
Yeah.
Second is a cardiologist asked, are there any effects of radiation? That's the second question.
Yeah.
I must say I never thought about that because, as you can see, I didn't have the issue. But anyway, radiation and hair loss, that's a great
Yeah.
question. And the third, someone just asked the role of biotin.
Biotin. Yeah.
Biotin. So these are the three questions which we
Sure.
can address now.
Sure, sure. Excellent question. So minoxidil. See, minoxidil is a vasodilator. It works by working on the potassium channel, and it was used as treatment for the hypertension in the higher doses. But then it was found that these individuals were getting the hair on the scalp, those who did not have it, and from there. This treatment was arrived sometime in 1988. So bottom line is that it is a vasodilator. So when it is applied topically, it stimulates the blood flow, and wherever there is an increased blood flow, there is more nutrients coming and more stimulation, except in case of cancer. Second question about the radiation. Yes, radiation does impact the hair growth by suppressing the follicular cells and its activation. Coming to the biotin, we know biotin labeled all about the hair, skin, and nail. So biotin does play a role in the hair growth, but it is a very small component. Taking biotin in isolation in a high amount, basically you are just passing it out in the urine. This cyclical treatment has a biotin, but you are taking in low doses on 2 different days, and that is more than enough.
That's great. There are some other questions on the nutrients, but they can be addressed to you later on. Dr. Ranga Reddy just asked, is there a limit in age to when you can have hair regrowth? I think that's a very interesting question.
Sure.
What is the age, if at all? I mean, aging,
Sure.
of course, is variable to all of us, but please.
Yeah, yeah. So, excellent question. So, as long as the individual has dormant hair follicles, empty hair follicles, or hair follicles in the prolonged resting phase, those all can be brought out to life with the help of medical management. Only the hair follicles which are permanently destroyed, that is where the hair transplant is needed, and that depends on the availability of the donor. And I have performed hair transplant in the individual as old as 86. It all comes down to the individual.
Great. I think in the interest of time, we can go on. It's interesting that you mentioned the COVID. It seems to link with almost everything in a
Yes.
different mechanism, whether to hair loss, as you mentioned, in terms of selective depletion of nutrients, or whether inflammation, which is responsible for everything there. Maybe you can address this question at the end.
Sure.
There's a good question about how do you address hair loss after radiation
Sure.
treatment therapy, but maybe you can address that. But if you just make a list of that,
I will.
that's from Dr. Alka. So I have not forgotten. I'm looking at the answers. So let's go to the next speaker, then we can address all the remaining questions. And if I missed some, my apologies. So the next speaker is Dr. Bhatt. Praful Bhatt, again, we are the Patagonia ex-alumni who spoke there on the same topics. And yes, in COVID, we may feel is not there, but it has left an impact in all specialties, whatever our specialty, whether it is cardiovascular, hair, I was not aware of. So Dr. Bhatt is an esteemed speaker and a professor. And Tarak, would you like to say a few words about Dr. Bhatt?
Yeah, Dr.
I
Bhatt
hope
is
I'm not.
from my medical school, Baroda alumni, 69, class of 69 or so. And then he's a teacher, teaches at Penn Medical School in Pennsylvania. And he's eager to talk about this topic. And he works a lot on the vaccine in children, and we were talking yesterday. It's we should have another discussion on the vaccine in children, where we are going nowadays. But go ahead, Dr. Bhatt.
Thank
Yeah.
you, Atul, and thank you, Dr. Vasavada. Thanks, everyone. Good afternoon. Thank you for joining and listening to all the presenters today. I'm going to uh, talk today about long COVID, its origin and current perspectives.
Okay, would you share your slide, Dr. Bhatt?
Yes. Is that seen now?
No. Go to the share button and then. Yeah, it's coming up shortly.
Okay.
Yeah, you're on the Zoom, so maybe you need to find your thing. Yes, make it whole thing slide. Yeah, good.
Okay. So I'll be talking about long COVID, and I certainly have no conflict of interest. I have nothing to disclose. Uh, Today's presentation, my objectives are to talk about the origin of SARS coronavirus 2, which led to a pandemic of COVID-19, and how this SARS coronavirus 2 has rapidly evolved over the years from the ancestral strain. We will talk about that. Talk about the goal of what COVID vaccine everybody expects it to do, and how the CDC has proven that COVID vaccine has its protection against long COVID. We'll talk about the mechanisms of long COVID, symptoms of long COVID, and we'll talk about the treatments proposed for long COVID. So, just a little bit of background on where we all started and where we are at present. So, this all started in October, November of 2019 in Wuhan province of China. There was an outbreak of viral pneumonias. Um, Unlike most viral pneumonias that we can think of, this was a totally different type of viral pneumonia that there was no experience about treating it. Uh, this SARS coronavirus 2 became very infectious. It was easily transmissible, and it became a pandemic in a matter of first few months. So these patients in Wuhan that presented with viral pneumonias, they had two distinct phases, two stages of the viral uh, involvement. The first phase was where the virus replicated and it was responsible during that phase as mild disease. But then soon followed the inflammatory phase, which really resulted in severe disease. These patients had uh, cytokine storm, had acute respiratory distress syndrome. They ended up in ICU on a ventilator, eventually developed respiratory failure, and some of them had multi organ dysfunction, uh, causing a large fatality in many patients. By January 11th, the scientists in China, the researchers, they revealed the uh, genomic data, the sequencing and the genome of the virus that was causing this outbreak of viral pneumonias. And that came out on January 11th. And this became known as what we know now as a SARS coronavirus 2, a very unique virus with spike proteins. Uh, and this virus, actually, the spike protein is made up of about 1,300 amino acids. Even a small mutation in the coronavirus amino acid situation can make the virus more transmissible. It can infect more cells. So this virus does mutate so rapidly. The first mutation took place in the 614 amino acid situation, and it mutated from D to G. And this virus has not stopped mutating since then. It's known for a very rapid evolution, and we have known some of the uh, variants. D614G was the first one. Alpha variant was the next one. Delta and Omicron is now what we have for the last few years. The Omicron variant has further evolved into almost like an alphabet soup of subvariants. And these are all the subvariants of Omicron that we have gone through over the last, especially 3 or so years. Um, what is currently the most dominant strain is the XFG in the last 2 weeks. As of 2 weeks ago, the XFG variant, which is also known as Stratus, that's the most dominant subvariant of Omicron. It's more transmissible than any of the previous variants. It causes about 69% of COVID, and the other 10% is with XFG 14.1. There are other circulating subvariants, which I have listed here: Nimbus and XDV1 and LF7. They are also circulating currently. Uh, the virus is ever evolving. It is constant. It's a process that's never ending. And this virus, even when it is the Omicron with some of the variants that people think they are of little significance, it still makes people go in the hospital. Uh, they are hospitalized, and it still causes death, especially in in elderly or people with some underlying disease, compromised immune status, obesity, diabetes, smoking, chronic lung or cardiovascular disease. And the statistics is almost every week about 300 to 500 deaths occur from COVID, at least as one of the causes of death. Last year, CDC came up with an estimate of about 47,500 Americans who had died from COVID in the year 2024. So everybody knows that these are the vaccines that are available. It's the messenger RNA technology, and the two big makers are Pfizer, BioNTech, and Moderna. Incidentally, as the COVID emergency was called off last year, now FDA has taken away the emergency use license of Pfizer, and it's only to be used in children 5 and above. Previously, during emergency, it was 6 months and onward. Moderna still holds the indication for 6 months and onward. And of course, the third one we know is Novavax, but it's only indicated in 12 and above. The Novavax is close to what other vaccines that we are familiar with, such as HPV vaccine, hepatitis B vaccines, shingles vaccine. It's an adjuvanted vaccine. The original strain, the ancestral strain vaccine, is no longer in any of the vaccines. It was used for the first 2 years, and then there came the bivalent vaccine where it was the ancestral strain plus the prevailing variant, which we had for about 2 years. And now, of course, it's only the Omicron subvariant that's in the booster vaccine that we have for the last uh, at least 2 years. The current booster vaccine has Omicron subtype LP81. Uh, a few things have changed recently. RFK Jr., the health secretary, has changed the government policy, and now the government recommendation is no vaccination for healthy children, no vaccination for adolescents, healthy adolescents, no vaccine booster or otherwise for young adults, but it's definitely indicated in 65 and above, and also in those that have at least one underlying risk factor, risk illnesses. So this is a big change from what it used to be. Uh, Talking about the what do we expect to gain from the COVID vaccine, and how quickly does the vaccine immunity fade? So, the first and foremost goal of COVID vaccine is to protect us against serious illness. So, it definitely achieves that. It decreases your progression of COVID illness from mild to getting to be severe. Once it is the severe COVID illness, you have to be hospitalized. You may end up being in the ICU. You may end up being on a ventilator, and it may even, on a worse basis, it may even cause fatal outcome. So the vaccine prevents that progression. to severe COVID-19 illness. That's established. It also reduces the incidence of long COVID. That's definitely established by CDC from many surveys, and it could potentially help slow down new variants. This is what it is. The new variants are ever going, constant change, mutations, never ending. But the more people are vaccinated, there's a chance that we may slow down the new variants. So people argue that they should be okay because they have had vaccine or they have had a COVID infection. So, in essence, between COVID infection and vaccine, they should have a hybrid immunity combined from both, and it should last them for a long time. But there have been studies done. There have been IgG and IgM titers uh, aga subsequent to the vaccine or the infection and the vaccine combination. The immunity is not forever. Even the hybrid immunity, it wanes over in about 8 months. And the immunity from the boosters only lasts for about 4 to 6 months. It fades after that. When it comes to immunity, yes, the young, healthy people, uh, they have a robust response, very solid immunity, more than 95% against severe disease after the vaccine. And it certainly prevents hospitalization and prevents death and disability. Unlike young people, in older people, especially when their immune status is compromised and when they have some underlying conditions, their response to vaccine is not as robust. It's compromised. Nothing as compared to young or healthy people. So people who are at risk, 65 and above, and with underlying conditions, uh, they could develop the severe disease. And it may make sense for them to get boosters more frequently because the boosters will only give you immunity for about 4 to 6 months. So some people, even the infectious disease experts, they say that they may be better off having spring and fall boosters. Now, we all know that the immunity is from two ways. One is the humoral immunity or B cell immunity, which we measure with neutralizing antibodies, the IgG, IgM titers, mostly IgG titers, and a T cell immunity. T cells, the immunity from T cells is more of a permanent immunity, longer lasting immunity. T cells have the memory that will hold the immunity longer period of time, and it will certainly kick in. At least in young healthy people, the T cell immunity will kick in eventually and will prevent you from getting to have to be hospitalized. Um, but that doesn't happen in elderly or those with obesity, diabetes. So the coronavirus 2 is not going to go away. Experts believe that it may last for a few decades. The Children's Hospital of Philadelphia Infectious Disease um, believes that it may last for a few decades. It's not going to go away. It's not that the weather improves and the virus is going to disappear. Um, the other thing all the experts believe is that the immunity from either the vaccine or the COVID illness, to think that it will provide 100% immunity, it is unachievable. It's not going to happen. all immunity fades eventually. So people need to get boosters to continue to be protected. And those with comorbidities and compromised immunity, although vaccinated and boosted, they're still at a greater risk of having a severe disease. Um, the research suggests that COVID 19 vaccines offer significant protection against long COVID. And I'm going to talk about long COVID in a little bit. Um, so this vaccine can prevent long COVID. The onset of long COVID, not only that, but even flare-ups can be minimized as we keep up with all the vaccines, COVID vaccines. Many a times, it's not the initial COVID infection that gives you long COVID. It is the second or third bout of COVID that gives patients long COVID. So, what is long COVID? We all remember that CDC confirmed its first US case of COVID 19 in early 2020. Early 2020, that's when um, we had our first cases in COVID 19 in US. 8 months later, the World Health Organization called a, a post COVID viral condition, which is now known as long COVID. So there is an estimate of about 8% of people who have had COVID have ended up with long COVID. 8%. And it amounts to about 23 million people who live with long COVID symptoms. So the World Health Organization has defined long COVID as having uh, symptoms 3 months after an initial COVID infection. And these symptoms are not explainable on the basis of anything else. And they last for at least 2 months or longer. The National Academies of Sciences, Engineering, and Medicine, they define long COVID a little bit differently. Again, it has to be subsequent to coronavirus 2 infection, subsequent to COVID, and it is associated along with COVID infection, of course. Subsequently, uh, for at least 3 months, these patients continue to have symptoms which are either continuous, relapsing, or remitting, or progressive, and the symptoms affect more than one or more organ systems. So, a little bit about the vaccine and the association with long COVID. What we know, long COVID rates are significantly higher in South, Midwest, and West, but they are not so high in New England and Northeast. Why is that? There are two things that go with long COVID. One is the severity of COVID infection, and the second thing is vaccination status. Low vaccination status has been documented in South, Midwest, and West, which is where the long COVID is. So the rates are higher. And the vaccination status is much better in New England and Northeast. So that's how it goes. Vermont has the best vaccination rates. CDC, of course, has confirmed from surveys that vaccination will reduce your chances of developing long COVID. Anybody with any of the morbid conditions such as obesity, hypertension, smoking, diabetes can also have higher incidence of long COVID. The why do we have to face long COVID? There are some explanations why. Like I said before, the severity of COVID infection, reinfection, because sometimes it's not the initial infection, it's the second or third infection that leads to long COVID. Um, Low vaccination rates. So what happened? There's something called vaccine fatigue. When in early 2021, the first set of vaccines, COVID vaccines came out, there was a high uptake of, very high uptake of both doses of COVID vaccines. And then there was not so high, maybe a little spike in the after the first booster and after the second booster. But then now we believe that there is something that we recognize as vaccine fatigue. People are just tired of getting these COVID vaccines, boosters. So vaccination rates have really plummeted. And waning immunity, of course, also leads to your risk of developing long COVID. Also, there is a decline in the use of antivirals. For some reason, there's some resistance to using antivirals, which is wrong. Um, Now we know there are a few things that have come to be known in the last year and a half. One is the long COVID because of viral reservoirs. So these are the viral fragments that remain in the blood or in the tissues after the acute COVID infection is over. They are viral reservoirs, and they are the cause because they cause inflammation and they cause multi-organ system damage. And certainly, some of us are not able to eradicate this virus. So it hangs out in the um, central nervous system. It hangs out in the respiratory system, hangs out in cardiovascular system. So the first and foremost is the viral reservoirs causing multi-organ damage. The second the mechanism is the change in the microbiome in the gut. The third stipulation is the alteration of the mitochondrial function and alteration of the T cell activity. The University of Pennsylvania researchers have also uncovered a link between long COVID and low levels of serotonin in the body and low levels of cortisol also. Now, these are some of the associations that have been established. Um, it would be best if we had the biomarker either in the plasma or in the tissue. That would make a definitive diagnosis instead of certain mechanisms. The biomarkers, we are still far away from having a 100% biomarker. We are close to about 80% so far. Um, the researchers have found elevated levels of core proteins, and I have put them down here. There is also a stipulation that FOXP4 gene locus on chromosome 6 has been associated with long COVID. Um, the There is this association of vitamin D deficiency, long COVID, and brain fog. There is a stipulation of microclots in the plasma, and these microclots will block this circulation of um, some of the terminal circulation of vital organs, and these are the organs that ultimately have damaged. Um, so the biomarker, which would be either something in the blood or in the tissue, we are still not close to it, about 80%. Once this is what happened with HIV also. It took years before we figured out how to diagnose with certainty the HIV infection. And we are getting close to diagnosing long COVID, but not quite 100% yet. So it has become a diagnosis of art, and it requires skills, experience, and intuition. Um, so, what is long COVID? What are the symptoms of long COVID? It is a uh, um, umbrella term. It's a heterogeneous disorder. It affects multi-organ systems. Um, it can affect many different parts of the body. And the most common symptoms are what I have listed here. The first 15, 17 symptoms: shortness of breath, palpitations, fatigue, post-exertional malaise. Even with slight exertion, these people get so tired. Sleep disturbance, postural orthostatic tachycardia, myalgic encephalomyelitis, which results in chronic fatigue syndrome. Some of the autoimmune disorders, brain fog has become a nightmare. These patients cannot uh, have cognitive uh, ability. They have definitely impairment of cognition. Their working memory is decreased. Their attention span is reduced. They can't reason out. So these people, they almost look like that. They have aged by 10 or 11 years. Um, Loss of smell or taste could take years before it will come back. Chest pain, dizziness, some of the gastrointestinal symptoms, headaches, muscle aches, joint pains. So musculoskeletal symptoms, chronic cough. Uh, like Atul was saying, long COVID has been uh, equivalent to having coronary artery disease. Um, so long COVID tends to reside in brain, gut, lungs, mostly, and heart. So the symptoms can be grouped under any of these, but essentially these are the symptoms. So they could be grouped under sensory group, fatigue group, brain fog group, cardiovascular group, respiratory group, GI group. Um, the other thing about long COVID is it does not differentiate in terms of education level, in terms of socioeconomic status. Uh, it does not distinguish um, uh, from the average socioeconomic status to high economic status. Uh, it affects the health groups, doctors, nurses, other health workers. It affects the toddlers. It wasn't thought before, but now it's believed that it hits the toddlers pretty hard. Pregnant women are also vulnerable to long COVID. Um, the long COVID has been going on after World Health Organization and CDC defined it 8 months after the start of pandemic, um, and it is still going on. It has been 5.5 years, and some of the patients are struggling with these symptoms, um, and we still don't have 100% biomarker to diagnose it. And unless we have 100% biomarker, the insurance companies or the pharmaceutical companies are not going to be interested in finding a cure or some research development for medications. So there is no FDA approved treatment for COVID at present. There are some stipulations.
Prabhul Bhai, you may have like a 5 minutes or so, or less than that. So if
Sure,
you don't
yeah.
mind, just moving fast.
So
Yeah.
long COVID affects so many different parts of body. It may take some time for us to really figure out how to best treat it. And there are not enough number of specialists to manage this patient. So it has come in the ballpark of primary care providers. The thing about reservoirs, the targeting viral reservoirs, and I think this is where the hope is. The antivirals and monoclonal antibodies. The monoclonal antibodies, once that infusion is given, some of these patients they recover from it and get over everything within a period of 1 week. That's very interesting. The monoclonal antibodies, what they help you fight off the virus from the body. They also displace the dysfunctional antibodies that are present on the cells, and they also neutralize the other viruses like Epstein-Barr virus, which may otherwise get reactivated and cause uh, uh, fatigue or exaggerate the symptoms of fatigue. So the antivirals are Paxlovid, certainly, and the other one is acyclovir. It has been recognized that acyclovir and Paxlovid combination or in the proper dosage and length of time, it could prevent and treat long COVID. Um, there are several trials going on using GLP receptor agonists and JAK inhibitors. There are some off-label uses like Plavix, naltrexone, rapamycin, triptans, beta blockers, nicotine patches, metformin, and SSRI because of the low serotonin levels that University of Pennsylvania came up with. Vitamin D supplementation, some complementary therapies, something as intensive as red light therapy, some over-the-counter supplements, vitamin B infusions, the blood washing or apheresis, massage, yoga, meditation, um, some of the mineral and thermal water therapy. But in general, the advice is be compassionate to these patients, show some empathy, explain to them the benefits of the vaccine. The vaccine could prevent the development of long COVID, and can also uh, prevent any relapses. Um, so you may have to explain the side effects of the vaccine if they have any concerns. But vaccine is COVID vaccine is a long way to helping. Um, these patients should pace themselves in a way that they can handle, refer to physical therapy, occupational therapy, speech therapy, anti-inflammatory diet like Mediterranean diet, hydration, improve the sleep quality. There are multiple trials that are going on, and we are hoping that some of these trials will come up with something more certain. Although 90 to 100% of people typically recover in 3 years, there are about 5%, even after 5.5 years, they have still not recovered. So, my final thoughts on this whole thing, this is a very rapidly evolving virus. Don't expect that it will go away. It's one of the seventh viruses that have come into human population, but this is a different virus. The ID experts have questioned whether COVID infection can completely go away. It's not attainable. It will last for a few decades. COVID vaccine is our way to go. It protects against long COVID. Uh, Having a full round of recommended shots may offer the most protection. Two setbacks that have occurred in March, the Office of Long COVID was shut down by Health and Human Services. So it has hampered the research. And the Trump administration has pulled back in funding from COVID research. And this has also hindered the efforts to understand how to best treat long COVID. I would like to thank my wife and our three adult children who have unequivocally supported my uh, uh, progress in the field of pediatrics. So I really thank them, recognize them, and these are my references. Thank you for listening to this topic. I will stop here.
Thank you, Praful Bhai. Maybe we could have, I've got two or three sort of nice questions.
Sure.
Someone asked, very interesting, why is it called long COVID and not chronic COVID? That's an interesting question. And someone asked about race and, predilection for COVID. You already addressed that it goes across sort of socioeconomic class and race.
Right, right.
I'm correct there. How does one get a disability from COVID? That was a disability from COVID, and why is it called long COVID and not chronic COVID? And someone asked about Actimera. I mean, those are three questions.
So, um, the long COVID and chronic COVID are synonymous. Um, you can also it can also be called as acute post-viral syndrome. So all of these point to the same situation of long COVID symptoms or chronic COVID symptoms. The disability, yes, I think it's a good consideration. There is no question about it. Some of these patients who have had COVID for many years, uh, although in general you can get over it in about 3 to 5 years, there are still about 5% of patients who are still suffering from it, even after using the antivirals and monoclonal antibodies. So they could be classified as disabled people. There is a process that they have to go through for it.
Thank you.
Okay, should we go?
Yeah.
Dr. Prakash?
Yeah. So let me bring my
Yeah, put your slide
slides
while I
up.
introduce you.
Yeah, sure. Let me bring them
So we
together.
have Dr. Atul Prakash. He is a professor of medicine and director of electrophysiology and chief of cardiology, and also director of research at St. Mary's General Hospital and Prime Healthcare in New Jersey. He did his FRCP from UK. He trained there and came here for research. And he is my partner in this endeavor of API co-chair for the CME. And so he's also interested in not only cardiology, but some of the spiritual health and meditation, etc. So I will let Dr. Prakash go from here.
Thank you, Tarak, for the kind introduction, and it's been a pleasure organizing this with your leadership and my help. So, inflammation, as Praful mentioned, has become the buzzword. It has become the buzzword of health, whether it is diet, whether it is the mechanism of many diseases, as you see on media, which is sort of widely prevalent. Something which has always intrigued me is, which I know we're all aware of, is why do we as Indians and South Asians have increased incidence in coronary artery disease and sudden death? Even here in New Jersey, we had a bunch of people who died sort of suddenly without any warning, which led me to dwell into this a little more as to why, and I'll sort of close it with a touch of spirituality at the end, which is very easy to talk about, but very difficult to imbibe in your own lifestyle. Disclosures for this topic, I have no particular thing, but for implantable defibrillators and ablations, I am involved in research in different aspects of atrial fibrillation and device therapy. So this is a graph which I always think perhaps the X and Y axes are not truly reflective of age, but we are born and then we die. But we all carry a different graph at which we wonder why, and there's someone who passes away at the age of 60 and someone who at the age of 90 is still going hunky-dory without any issues. And you have aberrations. You have sort of someone, right, who's 100 and some very unlucky human being who dies at the age of 30, which is tragic, as we all know, especially to those who are left behind. So needless to say, the person who goes, uh, there's no sadness for the person as you're gone, but for the people who are left behind, who have not yet reconciled even to a possibility of the loved one ever not being there in their life. So this is a birth to death. What can influence this graph is right the preventive aspects of cardiology and health. It's not only cardiology, it is health. Whether it's a vaccine with the COVID, or whether it is hair, as Balwant said, maybe hair makes you happy and you feel happy, which actually reduces inflammation and increases the lifespan. So all of these things are interlinked. There's birth and death. So happiness, all what we do, contentment, spirituality can all impact this graph, so we can live to be about 90 and we can have good quality of life. I must say, I gave this talk at a temple, and a lady sort of got up to my disdain. She said, well, I don't agree. Destiny is in God's hand. Well, I said, well, that may be your belief, but if everything is in God's hand, then why are we doing this talk? But anyway, so this is birth, this is death. So this is what I am a specialist for. This is an implantable defibrillator, and as you have a cardiac arrest, and the device gives you a shock, and you're back to life. And the patient comes to the office, and he tells me, "Hey doc, what the hell have you implanted in my chest? It gave me a shock, and I shook from one end of the room to the other." I do make him or her aware that, by the way, you're only here abusing me or yelling at me because the device shocked you and sort of saved you. So this is the culmination of healthcare and prevention if you have a defibrillator. But as you know, all of us cannot have a defibrillator because we're not deemed at risk of sudden death. That's the whole thing. In a population of the human beings in which you can predict death, you can implant a defibrillator to at least improve that, but you don't know. And the population we are sort of worried about is the 30-year-old, the 40-year-old, 50-year-old who has no symptoms, who sleeps at night and who doesn't get up, and leaves his or her family in a state of distress. So sudden death. As far as an electrophysiologist is concerned, that's how we were trained after cardiology. One group of issues is that it is an electrical issue. So this is the young person who has and who dies suddenly without any warning. I'll go back and forth. So primary electrical is not specific to us. It is not specific to South Asians. It is specific to all concerned, mainly genetic. And you've heard of entities like, Hank Gathers, or a basketball player or sportsman. All of a sudden, he dies suddenly. So these are electrical abnormalities, most of them, though there are some mechanical abnormalities as well, mainly sort of genetic. You may have heard about them: long QT syndrome, Wolff-Parkinson-White syndrome, primary ventricular fibrillation, Brugada syndrome. I have put in hypertrophic obstructive cardiomyopathy in that, though it is not a pure electrical issue. I mean, how do you prevent this, or rather minimize this? So the family history of all of us, family history of a sibling or a parent dying at a young age, should lead to some kind of screening. And the screening is very simple: an EKG to look for electrical abnormalities, and a simple stethoscope, which I must say, and the residents, I hope there are some fellows who are attending this. I've asked them to attend, and the stethoscope is still a golden tool to detect murmurs. Everyone doesn't have to have echo. Everyone doesn't have to go through the motion of an echo. EKG and a stethoscope, you can diagnose most entities which can give rise to sudden death because of a mechanical issue. Just a murmur and an EKG. EKG can also help identify some of these electrical abnormalities, which also give rise to sudden death. So these are mainly genetic, and they come out of the blue, but they can be screened if you look at the family history, if you look at even the minor symptoms. Clinical medicine is still extremely important. Again, I emphasize this over and over again. And the history, when you take a patient, this should be inculcated in our in our residents and fellows. It is not all about doing testing. It is not about doing X-rays and imaging and MRIs. And the history still can sort of guide you. Simple conversation whether there is someone at risk of death or sudden death in sort of many institutions. The other cause of sudden death, which intrigued me more so than my subspecialty of being electrophysiologist and doing ablations left, right, and center, implanting devices, is this which came to my notice. I was in Delhi. I was in an intense. I was a senior resident after MD medicine. For those of you who've done that, in a cardiology unit, and we had a bunch of people and who came in with massive heart attacks. So they did not only come in with heart attacks, these were massive heart attacks which wiped out the whole of the whole anterior wall, and it left them really highly symptomatic even after recovery. Of course, at that time, after a heart attack, you did not have things like opening up an artery, STEMI intervention, angioplasty, and you did not have defibrillators, which in the late to mid 80s were really evolving. And the first defibrillator was then implanted, and it was a big device, and it was not available, and the data had not come out in science. So it is us, Indians and South Asians. So we occupy 1/4 of the world population at the moment. I must warn you at the moment, or I must tell you at the moment. But 50% of the CV deaths are because of us and South Asians. Asian Indians have the highest incidence of CAD with the worst outcome. So not only do you have a high degree of prevalence incidence, you also have a worse outcome. Like I mentioned to the patients I saw in their 30s, it is more severe at a younger age. Initially, I thought that it was more severe because when you are young, you don't have the collaterals. That means if one artery goes, you don't have this sort of balancing phenomena of the other arteries to minimize the extent of damage. What I mean is we have a higher incidence of multi-vessel coronary artery disease. People initially thought that it was people from India who came to the West and the diet changed, but no, it is as prevalent in Indians in India as much as Indians and us who came out to the West. And there have been speculations here and there as to why, and I will allude to that sort of somewhat. And the first analysis of all this came out in England. It came out with in a town called Leicester. So Leicester has a high proportion of Indians, and it was felt that the first speculation was that Indians have small arteries, and the second speculation is metabolic syndrome. All these do hold true to some extent, but we didn't know the whole spectrum of the risk factors of what gives us coronary artery disease at such a young age and which is so bad and so severe. So I mentioned higher proportion of multi-vessel CAD, but the conventional risk factors don't entirely explain the magnitude and the severity of what we face. So this we all know. I won't dwell. I mean, all of you read and are physicians and cardiologists and interventionalists. I mean, we're all aware of these, right? Diabetes, of course, a low, high HDL, obesity, smoking, hypertension, metabolic syndrome, and the last but not least, inflammation. So as Praful Bhai was talking, inflammation was responsible for many people dying all of a sudden when we had in the presence of COVID. I know some people I treated, they just died suddenly. And we merely speculated whether it was acute pulmonary embolism or whether it was a phenomenon called as plaque rupture. So plaque rupture is something we are worried about, which kills without warning, in which an individual has no symptoms, no angina, no chest pain, no shortness of breath, and boom, in your sleep, and one fine day you go. That is because of plaque rupture, and that happened to a large extent at the times of COVID, and indeed at the times of antecedent illnesses which we have seen. So inflammation is the new buzzword, which is very important. And that's where all the spirituality, diet, exercise, and all that comes into play, which has always been important, but we never knew why it was so important in the prevention of sudden death, especially ourselves. So these are the conventional risk factors. If I'm going a little fast, I want to have some time for everyone to ask questions to the others. Now, in red are the risk factors for us. Risk factors with a greater impact on Indians. The AHA, ACC for the last 3 years have been now recommending testing for these lipid issues, lipoprotein A and apolipoprotein B. When I did research on this, I did it for myself and for my patients. There was data on this from the Indian journals as far back as the 90s. It pains me that we didn't look at our own journals, but then when we came to the US, when the US and the AHA acknowledged it, then we started paying heed to this. But we have data in our Indian journals in the late 90s and early 2000s. So lipoprotein A and apoprotein B. And the cholesterol subvariants that we have very low HDL. We have dysfunctional HDL. So HDL works that it is anti-inflammatory. So it's good to have a higher level of HDL. But again, a caveat is HDLs over 80 start to become pro-atherogenic. So I mean, too much of everything is bad. A good amount of HDL is good, but when it becomes too high, when it becomes beyond 80, then you start sort of wondering. Then it becomes a risk factor also. The higher levels of homocysteine because of B12 deficiency. I mean, these are different papers, small papers, but in the world of nutrition now, which Balwant alluded to, a lot of these things can be taken care of. Insulin resistance, metabolic syndrome still holds true because it is a precursor for inflammation and your A1C. With this, I have to say, if there are any endocrinologists who are listening, I have this constant struggle with the level of A1C and with the level of LDL, which my endocrine colleagues. The Indian and the European guidelines say LDL should be under 55 if you have a family history, and if you have had a coronary event, and A1C should be under 5.6, 5.7, but there seems to be a disparity in views with my endocrine colleagues. So metabolic syndrome, insulin resistance. This is also new, impaired ability to repair blood vessels, endothelial dysfunction. So these are some of the mechanisms. Inflammation, which I have alluded to, I'm looking at the time, and truncal obesity, right? Adipokines. It is very strange. Apart from truncal obesity, there's something called as visceral fat. Balwant has seen me. For those who have seen me, do you think I have a high proportion of visceral fat? Some of you will say no.
No, I don't think so.
Yeah, so that's the amazing thing. Visceral fat is not reflective on your overall habitus and your BMI. So there are screening tools for that. Small arteries, again, that was the old concept in the early 90s, which still holds true. And elevated triglycerides is also a risk factor for early coronary artery disease. So lipids and lipoprotein A, genetically determined. I have left out the levels for all of you who are very specific. I'm sorry about the spelling of African. Maybe I didn't do my spell check appropriately. Appalling spelling here. So this is high amongst us and amongst the Africans. It is a very, very strong risk factor for Indians, especially. I check it on almost everyone who has early coronary artery disease. I also check it for those who have early aortic stenosis. People argue that it cannot be treated. It can be treated by existing approved medicines, though the medicines are not approved to lower lipoprotein A. It is a byproduct and sort of benefit, and the drugs which will lower it specifically should be out in a year. the third question is, people say, well, even if you lower it, does it improve the outcomes? I mean, and you have two choices with any intervention, whether it's a vaccine or whether it's hair transplant or whether it is a drug for hair. You can wait for outcomes. My feeling is, if you can extrapolate data and the risk of intervention is not high, are you going to wait for outcomes? A lot of us will be dead by then, and then yes, on our grave or our cemetery, people say, yes, it improves outcomes. So yes, there are drugs, and to lower lipoprotein A, it is a stronger risk factor. It is 6 times more thrombogenic than your LDL. It causes both thrombogenicity and it causes inflammation. It also causes increased atherosclerosis. So I mean, the process is that you deposit cholesterol, and one fine day and the plaque ruptures, but the deposition of cholesterol is, of course, inflammation. So I mean, the take-home message of this talk is inflammation, 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 which is so important. Certain specifics of lipoprotein A, again, genetically sort of determined. It is recommended. All the associations, AHA, ACC, recommend that we must check it for your early CAD and worse CAD, and if you have a family history of coronary artery disease. Lots of drugs which show reduction of this agent, but of the available drugs, PCSK9 and sort of niacin also has. Interestingly, lifestyle modification has no benefit in this. Diabetes mellitus and hypertension, yes, we know there's a high incidence both in us, both in Indians, and the incidence of coronary artery disease by, again, insulin resistance and different ways of actually working. Obesity, you don't need me and to attend this talk today to know that obesity is a risk factor both for coronary artery disease and for a sudden death. But again, like I mentioned, BMI is a little spurious. It does not take into account the distribution of fat. And I mentioned visceral fat, then you have different indices of waist to hip ratio. South Asians have the highest level of visceral fat and intermuscular fat and hepatic fat. How can we improve it? Exercise. So, screening. Screening for a family history of coronary artery disease and sudden death. If there's a history of sudden death, which is defined as either unwitnessed death or death occurring within an hour of the onset of symptoms, should make you want to be screened. Syncope. It doesn't mean everyone who feels a little dizzy, which we've all done, we're at risk of sudden death, but one should look at it. Symptoms. Fatigue is an unrecognized symptom of underlying risk of plaque rupture and a heart attack and coronary artery disease. Of course, with our COVID talk, it may also be long COVID, it may be some other illness, but fatigue is not to be taken lightly. Basic testing, clinical exam is essential. Electrocardiogram, echocardiogram, and the blood testing, which I've just outlined, especially if you have a history of early coronary artery disease. Inflammation is a key to sudden death for a wide variety of reasons, not only plaque rupture, acute pulmonary embolism. It can be identified with different parameters, high sensitivity CRP, homocysteine levels. They can all identify a high pro-inflammatory state. COVID, influenza, all increase inflammation and have led to sudden death. Not only are at risk, I've seen it on some friends, I must say, and of course, through the eyes of my patients. What causes inflammation? Diabetes, lack of exercise is essential. Alcohol, as you're all reading, alcohol, even a single glass of wine can cause inflammation. Inflammation also results in cancer risk as well. Should you drink alcohol? Should you not drink alcohol? In life as a physician and as human beings, I tell the patients it is called the price and pleasure equation. What does that mean? When you get pleasure in something, there is a price. And you've got to make the calculation, you've got to do the maths, whether you are willing to take a risk with that. But I mean, certainly, I mean, no alcohol is ideal. Do I do it? Do we do it? Not necessarily. But I think to minimize this. So reducing sudden death, you have all the risk factor modification, then you do have medical intervention. I would just be very aggressive on these things, on low cholesterol, diabetes, inflammation, obesity. These are not just words thrown around. This is in our hand. And as the lady told me at the temple, I cannot leave it all to God and say it's God's will and just leave things alone and still not do anything to minimize and to prevent it. Risk factor modification. So again, treatment, as you know, statins, in terms of medicines, I think I have found in my practice, we are 2 lakhs. We are 2 lakhs on lowering of the cholesterol, in part because the labs don't emphasize it, but really, if you have a family history, LDL should be under 55. Lipoprotein A, it can be lowered by the use of niacin and PCSK9 inhibitors, and the drugs are in trial, which will be approved in about a year. A1C as low as you can go. So I have also met some esteemed, lipidologists. That was not my subspecialty. Everyone lowers their own cholesterol, own LDL, raise their HDL to as low as they can go, and the A1C, and they talk between 5.6 and 5.5. So that's where we're at there, as low as you can go. A high sensitivity CRP, sort of colchicine is the old drug, but adopted for this new use recently. There's some data on it. I must add, inflammation has become associated with atrial fibrillation also. We are actually working on inflammation and atrial fibrillation in our department, and we have some sort of papers coming out. But yes, atrial fibrillation also, apart from sort of sudden death.
Atul, by 5 minutes.
5 minutes. So now to start sort of closing, we've talked of the bad part. Now, what can we do about it? Moderate exercise. I don't know how many people I say, do you exercise? So, no, yes, we walk. I mean, walking is just one part of exercise. And at the end of my talk, my wife will be upstairs and she'll say, and you talk the talk, but you don't walk the talk. So we all have to exercise. So after this CME, I urge all of you and to pick up your dumbbells, to pick up the bands and exercise. I will be exercising. I'll be forced to exercise and to reduce my cardiovascular risk by my wife. So yes, walking is not enough. Strengthening exercises. Why strengthening? When we have lost Balwant's opinion, we've lost our hair and it's become white and white and white. We want to be able to stand up when we're 80, 90. So and you've got to get your muscles stronger and you've got to reduce the inflammation. Diet. Vegan, vegetarian, pescatarian. What I tell patients, I say meat is uniformly bad. I tell them, and I have no qualms about this, it's not political. I tell them meat is bad for us. It is bad for environment, whatever you believe in. And it's bad for the poor animal who gets burnt and get killed just to be eaten. But from a health perspective, it causes inflammation. And the rest of it is actually philosophical. But yes, it is bad. Fish is excellent, though on a philosophical discussion, it doesn't apply. Vegan diet, I myself don't do it, but you have loads of data on a vegan diet that even milk is pro-inflammatory, as I'm sure Balwant will allude to later. Happiness, oh my God, how can we have happiness? In India, I saw we have, laughing clubs. Laugh as much as you can, laugh as much as you can. Yoga is the best exercise. I am so sad that all my life, I only started this about 3-4 years, and I owe it to my wife who's listening here and will give me a lecture after this, that I still don't do the right form. Yoga gives you strength, it gives you meditation, it gives you happiness, and it reduces the inflammation. And it comes from where we all came from, but we don't do it. You know why? I must comment. Our teachers in yoga were absolutely pathetic. I'm sorry, I don't want to take it. I don't want to take the light out of Ravi Shankar, etc. They are absolutely pathetic. And it is the Western people who brought out yoga to all of us. That's the truth. It is the key to health, mental peace, as well as physical development. It creates strength also. And our gurus do not fulfill the true depth of the benefit. I'm very candid here. The West has brought out the true benefits. Excuse me, stress, unquantifiable risk factor. How do we quantify stress? It is not the stress. It is the impact of the stress on us. Why? I mean, why do we ever get impact? It's our personality. It's our mindset. So we can do this. And you have yoga, vagal breathing, emotional relativity, so on, spirituality. It is amazing. When do we all pray? Let me ask you. Most of the time, most of us, the most unreligious of us, only pray when we have stress with us. Okay, hey Bhagwan, or God, let me keep out the denomination in the equation. I don't want to upset anyone. God, forgive me, get me out of this trouble, and I'll never do anything again. And I'll be thankful to you forever in my life. Most of the time, most of our time, pray, we do that. And the second time we pray when we go to an institution. And we pray there because we have to pray. But you know what? All of it is good. I was very, very cynical that, oh no, it should be for only selflessness. It's like, no, whichever way we can adopt religion, whether organized religion, whether for us, whether for someone else, that's a matter of approach and attitude. Organized religion, form less belief, just true spirituality, whether the Buddhist philosophy. I don't become an un-Hindu by talking of Buddhism. I don't become an un-Hindu by saying some other faith is also has something good. Let's imbibe the all of faith. And this was a trial. This was a great meta-analysis to return back to the scientific forum. Patients receiving spiritual care during serious illnesses report better quality of life and outcomes. Lowered healthcare costs in this era of increasing healthcare costs when spiritual needs are addressed, improved immune system functioning, improved recovery rates. Spirituality and the nervous system. Spirituality is in the prefrontal cortex. This is the part of our brain which needs to grow. It can suppress our primitive instincts, our emotion, and some others. So we need this prefrontal cortex to control it for our peace of mind, to do good and to do good for others and to do good for ourselves. Let's forget, if you're not interested in others, if you're only interested in yourself, if you become spiritual, you'll do good for yourself. No one is invincible. Recognize the risk factors based on family history. Recognize the most minor symptoms. If you're feeling tired, don't pass it off. Get to it. Diet and exercise, lifestyle modification, stress. My wife has just walked in and I'm sure she'll urge me in 15 minutes to get on to exercise, and the price and pleasure occasion. And on a spiritual note, Merry Christmas to all. Merry Christmas to all Hindus, Christians, Muslims, Jews. After all, what a world do we live in when we can reach God through all means and all individual means so we want. Thank you very much.
Thank you. Great. Atul, you have some questions. If you want to take it from there.
Yeah, so I had some questions which I was asked. I think I mentioned about, for me or for others?
No, I think let me start, because you're busy with this thing. So let's just talk about a few things. I think the question starts with effects of statin on LPA, and do they reduce anything? I think you said about some new medications coming out, and I'm not sure about this. Do HDL particles matter?
So I'll answer the other and the second, and the particle size is important. Yeah. But based on the drug availability at the moment, and to cut the chase, so as to say, statins are the mainstay at the moment because of their pleiotropic effect. They're anti-inflammatory also. So they are the mainstay of the treatment, yet they do not improve the lipoprotein A. In fact, they increase the lipoprotein A in an indirect way. So in a strange way, and you combine inflammation and you combine LDL and you combine HDL. HDL doesn't matter. The only thing which increases HDL is exercise. We don't have a means to increase the HDL. Statins may increase the HDL somewhat. So if you cannot lower the other risk factors, you must lower the lipo the LDL to 10, 20 in that range. So if you have elevated lipoprotein A, your LDL should be as low as you can go, 15, 8, 10, because it is additive. You can add 6 times your LDL becomes your lipoprotein A. So you do the maths. So of the drugs available, PCSK9 inhibitors, right? Repatha and all do lower. Niacin does lower. Ezetimibe does lower from about 15 to 22% and change. So they do lower lipoprotein A. And the drugs which are coming out are, one of them is, lepindocercan. There are a bunch of them which are on trial, which we're involved with, and they are almost magical in lowering lipoprotein A. Until those drugs are approved, it is statins without elevated lipoprotein A, or a PCSK9 inhibitors with the use of a statin, and you just lower your LDL as low as you can go.
Okay, the next question, I think there's more comment from Dr. Bhatt about, I think you mentioned this thing, let's keep this thing. Anything that people sometimes worry that statins can increase hemoglobin A1C? It's possibly very minor, but what is your opinion?
So there is data on increasing, and also from personal experience. Well, you have a great drug called metformin still. So you add a metformin to a statin. I mean, the benefits of statin is not impacted by some marginal effect on A1C, and you can lower your A1C by the use of concomitant metformin as well, and exercise and all the things. So it is all of the above. I would not let it deter anyone not to use a statin for that issue. And people ask about sort of if you have a very low LDL, are you at risk of sort of dementia? We don't have any data. On the contrary, there is data to the contrary of improving even dementia, but all small studies. So at the moment, just lower it and use metformin if your A1C is so it can be impacted, yes.
And I think some of us are reaching that stage where, what age that you will stop statin, or would you not?
You would not stop. Remember that graph I showed you at the beginning, birth and death.
Yes.
So all these things should have been implemented at the age of 18 and 20, but we were not aware at that time, and science had not advanced. And like anything we do in science, it depends when science gives us the know-how to implement. Now that we know it, and you implement it early before the process of atherosclerosis starts, and there's no limit. I think you should be on statin all your life. Disclosure: I have no shares in any of the statin companies at all. It should be for life. And whatever I recommend, I do for myself. Let me put it this way. That's a disclosure.
I think you said very right, which some of the questions kind of says these things. The spirituality, religion, yoga, relaxation, stress management should be taught very early on in school or even at home. And if it's not done right, you probably, stressors as a child, even the adverse childhood events that we see in the United States, a lot of kids we see are abused, and then what happens to them down the road, their immune system, everything is just a whack. So I think all those things are important along with that, which you mentioned, which is great. I'm not sure if you want to come back and go back to some of the questions. We have only a couple of minutes left.
Yeah, I'll just point out, let's forget the United States. Even in our social, in our culture, the whole emphasis on, beta, you must do, and you must top the exams. I mean, the role of exercise and all is emphasized less, even in our culture. Anyway, please, yeah.
I think it was one question interesting for Balwant. Indian, we always talk about the Sirsashan, Champi, castor oil, this oil, that oil. I'm not sure if oil makes any difference. It may just look whatever you have left is good, but what is your call on that?
So, coconut hair oil.
Yes.
The compounds of the coconut hair oil has been scientifically shown to decrease the sensitivity of the hair follicles to DHT. So there is a science behind it for sure. All the other oils, every oil has a benefit to the shaft structures for sure. But the best to use is that take oil which is 80% coconut, and to it you add whichever oil you want. Coconut, rosemary, castor oil, rosemary, etc. And it is going to work. Is it going to result into a head full of hair only on its own? Very unlikely.
Yeah,
but
it prevent probably, yes.
Yeah.
And what about there's some people are asking, which may be your trade secret, is what is this triple cyclical nutrients? How do you do that? But,
so this study was done by Dr. Rajesh Rajput, who actually has come up with this since more than 30 years back. And he there are over millions of people now on this therapy. And in my practice also, I provide this plan. Otherwise, as I have shown on the slide, one can make one's own plan according to what I had indicated, or they can contact me and I can guide in the right way. But that is a smarter way to take vitamins. And also coming to the question of Sirsasana, which I myself, I do not know any scientific study behind it, but I myself have been doing inversion since 2009. It is one exercise that I have been doing on a very regular basis. I hang myself upside down on an average for about 10 to 12 minutes per every day in in three sessions, like not all at one time. And I have been doing this 2009. I started it for my back, but it is when you invert it, you are increasing the blood supply to the skull temporarily, and you just have to take it at its value.
Okay.
I think it is helping me.
Great. Last question for Praful Bhai, I think, is somebody asked me twice here. Is there a long-term COVID effect of lung cancer or any kind of other disease, or even the small platelets clots happening later on?
The microclots are one of the reasons for long COVID. There's no question about it. But the best results are with the monoclonal antibody infusions and a combination of some antivirals, such as Paxlovid and acyclovir. I see that somebody was asking about
cancer, I think. Am I right? Was it cancer?
Yeah.
Yes.
The lung cancer, not that I'm aware of.
No, okay.
I don't think there has been a long-term study in terms of that being the sole factor for causing lung cancer. Maybe there is a combination of factors that may be responsible in a limited number of cases, but not always just because of the long COVID. Long COVID can result in chronic cough, chest pain, and some interstitial lung disease, but I'm not aware of any lung cancer.
Okay. And I think one more question for Atul Bhai, which is for pediatric age group, at what age would you say start statin? I think you answered that. So
yeah, as early. I mean, the age has not been defined. I mean, and the pediatricians might address to, but I have certainly started it on. Depends on the level. I mean, if you're younger, you will try the diet and exercise a little more than you will when you're older. So if you're in your 20s, 25, and again the other variables. I mean, family history of sudden death. If you have primary familial hypercholesteremia and your LDL is 240, then you will. So you'll have a sort of higher threshold, but and you'll take into other risk factors as well, and you have more room. I mean, in your life, 60 to 80. On that graph, you have more room to play with than you do when you're 60 or 50.
Okay, I think we are ending it here. There are some comments especially made for Balwan, so you should read it, Balwan, the last comment.
Yeah. When I said that, please, one should not start inversion just out of a blue moon.
Yes.
There are all the precautions that one needs to take. No question about it.
Right now, I think only person who doing inversion is Amit, because every president has to go through the inversion therapy.
Yeah.
And I think you should attend Amit's townhouse. I highly recommend. Amit has
thank you so much for
long history of knowing API, and he knows the API like anybody else would not know probably. So again, CME, you will get email in 4 to 5 days, probably Wednesday, Thursday, will pop up from the EMED events. Just looking up in the spam box and just fill out the quick your survey, and then they will send you the email right away at that spot. So Great talk. I enjoyed it, and I'm glad we are doing it on the U.S. soil. So you're all international speakers now.
Thanks.
Thank you, thank you so much.
Amit, go ahead.
Yeah,
Amit.
yeah. I mean, I think before we end, thank you, Tarak, for teeing off that town hall meeting. That's something which we started this year, and for all those people who are on the sidelines asking what's going on, is there any questions they have, any hot questions, any hot? We are open for those questions. That's what I want you guys to please join tomorrow. We sent out a new newsletter today. We also are announcing a new trip, Eastern Europe, like we talked about earlier. That's for people who actually said that, hey, if it was summer vacation, summer time, we could have easily gone, because otherwise we cannot take kids out of school. So this is a trip specially done for that, seeing the popularity of the China trip, which got sold out 6 months in advance. So please try to attend. But more importantly, please attend the town hall meeting and address all your questions. Your questions about, hey, anything on RP. You have questions, what's going on? We are there to answer directly to you. So this is the first time we're doing it. The second town hall meeting. First one we did it in, I think, July or August. Every 3 months we'll be doing it. Please join. And if you have any question to send before, please send it to info@aapiusa.org. You can send your questions. We'll have that ready. Otherwise, no issues. You can ask it impromptu, like Tarak said. If you have any questions, I most likely will know the answer. I may refer to Vijay once in a while, but most answers I have it, because I've been with API for 25 years. We are headed in a very good direction. And we want all your support to get up the momentum, the wind behind our sails to get it going again. So thank you, everybody, for joining. Thank you, Tarak, Atul, and the speakers for doing such a wonderful job. As usual, the CME talks have been stellar every month. I told you before when we started, we will not be having our CME talk next month, but we'll resume on third Sunday of February and we're concentrating more on younger speakers. And we have got a urology section forum speakers, and we've got emergency medicine. So all those things are coming up in the works. So we'll keep you informed. And thank you again for joining. And please don't forget to join town hall meeting tomorrow night. It's in the newsletter. And if you have any questions, please send an email to info@aapiusa.org. Thank you again.
Thank you.
Bye.
Thank you. See you in
Thanks,
third
Amit.
week of February from here.
Thank you.
Thanks.
Thanks, Amit. Thanks, Tarak.
Bye.
Thank you. Bye.